Good afternoon, everyone, and welcome to this session, this workshop on Lp(a). My name is Pasquale Maffia. I'm a professor of cardiovascular immunology here at the University of Glasgow, and it's a pleasure to co-chair today with Florian Cronenberg, which is very well known to this community. I'm speaking on behalf of the British Pharmacological Society, which is the largest learned society in pharmacology globally, and this is a joint session between the EAS and the British Pharmacological Society that I'm representing as the Vice President for Engagement. There is a large community of cardiovascular pharmacologists which are attending this conference, and this session is perfect because it's identifying, of course, targets for treatment. And without any further ado, I leave it to you to present the first speaker.
Yeah, also welcome to this session also from my side, and it's my great pleasure to opening this session with a talk from Sam Tsimikas. He will talk about Lp(a) and the new target. And Sam Tsimikas is coming from the University of California in San Diego, and I think he made major steps to bring back Lp(a) to the stage, and I'm looking forward to your talk, Sam.
Great. Thank you very much. Welcome, everybody. Let me get oriented here. Okay, great. So here's my disclosure slide. These are all related to my work from UCSD. So let me start out with a little bit of a historical context, and then some of the pathophysiology for the first half of the talk, and then I'm going to switch over to some of the recent developments for developing therapies to lower Lp(a). So this is Carey Berg. He is the founder of Lp(a). This is when he was about 60 years old, and he published this single author paper that you see here, and notice that there was no mentor in this study. He actually did this when he was a postdoc, and it happened to be his fifth paper in his career, and then he had the very nice privilege of spending the rest of his career working on Lp(a). So only if we could all be so lucky, but that's basically was his career trajectory. When he discovered Lp(a), it was a case of serendipity. He was actually looking for new blood types, and that's why you see here it says a new serum type in man. And of course, it wasn't a blood type, it was actually a new lipoprotein. And initially, it was thought it was a binary trait. So you have yes, no, and you can see this on the agarose gel here, that there's one band. But ultimately, we realized it was a quantitative trait. So if you go through the history here, and you see from 1963 and its discovery for the next 10 years, not much happened. There was a description by his group and others that it was associated with cardiovascular disease, and that's when the interest started taking off here, but it's still fairly quiet until about 1987, when there was an association with apo(a) with plasminogen, and all of a sudden it was thought that the secret sauce was discovered for atherothrombosis. Here's a lipoprotein that also can induce blood clots. Huge flurry of activity at this point until about 1994 or so, and then he quieted down because it was very difficult to find a relationship to thrombosis in vivo. And at the same time, a very prominent group in Boston published that there was no association of Lp(a) with cardiovascular disease, with a faulty assay that ultimately was corrected. About this time, we were working on oxidized LDL, and we actually discovered that Lp(a) has oxidized phospholipids on it, and it was a preferential carrier of oxidized phospholipids. So all of the work we were doing on oxidized LDL was very interestingly, we discovered that in plasma at least, it was Lp(a) that carried the majority of the oxidized phospholipids. And along with this, we started working on a therapy. There was additional work with Ionis Pharmaceuticals to develop a way to lower Lp(a), and then the genetic revolution came along to discover Lp(a) as a genetic risk factor. In fact, it was a rediscovery because that was actually done by Gert Uderman's group already, but this was really large-scale epidemiological studies. And then ultimately, the first proof of concept for an ASO was done in about 2011, and then now we're close to having a test of the Lp hypothesis. So I was there's a huge number of people that contributed to this. I thought I would just take OpenAI and ask it how many people contributed to the LPA story. And without going into a lot of detail, it came up with 31,000 co-authors. So just about everybody has touched LPA that's been in the lipid protein field, and so it's a huge community of people that have contributed to the story. Now, you all know LPA very well. Our contribution to the field has been that we documented that the ApoA component that you see right here can bind to oxidized phospholipids covalently, but it's also present in the lipid phase, and the one in the lipid phase can come on and off and accumulate according to how much oxidative stress there is. So the OXPL is an interesting component. It's not part of LPA per se, but if a patient has another hit of increased oxidative stress, this comes onto the particle, and we measure this in an assay called OXPL per ApoB that summates both of these processes. And I'll review a little bit of that for you in more detail. Now, when a lot of people started working on LPA, it was thought to be a curiosity, you know, rare disease, somebody you finally check the level, has multiple events. But that's not the case. It's actually present in about 1 in 5 people that you already know about. I just wanted to show you this database from a US laboratory that we put together. If you look at people that have LPA over 30, it's actually 2.4 billion people. It was about 1 in 3 in this laboratory. And so it's very, very common. Even the patients that have extremely high LPA levels, at 1% of the population, represents about 70 million people. So it's a daunting risk factor, and it's actually more prevalent than LDL and triglycerides combined, I think. Now, the LPA gene is thought to have evolved in Africa in all the different isoforms, so there are population differences around the world, but if the LPA is elevated, it's a risk factor no matter where you are in the globe. And you can see here the founders that left Africa, depending on where they went, brought their isoforms with them. So in the East Asia, for example, has the lowest population average levels, largest isoforms. The most prevalent LPA is actually in Africa and India, and then the other countries are somewhere in the middle. Now, there are 3 major proposed mechanisms for atherogenesis. There's the, or atherosclerosis and atherothrombosis. There's the proatherogenic effect, the antifibrinolytic effect, and the pro-inflammatory effect, which appears to be local and not systemic, so you don't have a correlation with CRP. But what we're learning is that the atherogenic effect appears to be minor from the ApoB perspective, because ApoB is a minority particle in LPA, and the prothrombotic or antifibrinolytic component appears to be also questionable. And so where does that leave us as a risk factor? It leaves us more with the pro-inflammatory effects, possibly driven in large part through its presence, its content of oxidized phospholipids. So we, as I said, kind of stumbled on this association of OXPL and LPA when we're looking to measure minimally oxidized LDL in plasma. Joe Whitstam and I were working on this, and we first applied it to clinical samples in 2003, and we noticed this very interesting association. We were expecting to find a high correlation between what we called OXPL per ApoB and LDL, and if you look here in the pink, it's modest and very weak. Instead, we noticed there was a strong association with LPA. And so this is how we got started on understanding this and thinking about a therapy for it, and here we are about 25 years later. The next couple of papers, we were able to document that it's a preferential carrier of oxidized phospholipids and monolipoproteins, and we did this with John Chapman's group and others, and then we eventually teamed up with Marlis Koszynski and her group to be able to pinpoint some of the effects on the ApoA particle. So I like to show this slide. This is actually quite instructive to show the relationship between oxidized phospholipids and LPA. And these are 3 patients, LPA of 10, and LPA, as you see here, of 50, and then 136. Whoops, sorry about that. So if you now do very fine gradients and do very, very fine cuts, which Alexina Orsoni did, she was a postdoc with John Chapman, and then you have 24 fractions, and then you ask the question, where's the ApoB, where's the LPA, and where's the OXPL? And notice here, the ApoB in red in all 3 patients is about where it's supposed to be. So you start from VLDL here and go all the way down to the lipid-free fraction. And then you look at the ApoA here in blue, and that's where it's supposed to be. And then you look at the OXPL in yellow, and you see here there's a little bit of OXPL across the entire density range, but in this patient with low LPA, there's a peak under the LPA peak, and then here in the modest elevated LPA, you see a lot more OXPL, and then in this last patient that has very high LPA, you see that the OXPL peak overtakes the LPA peak. So this has told us that the OXPL is physically associated in the same fractions that are primarily, but not exclusively, Lp(a). We then developed an ELISA to measure OXPL per ApoB for clinical use. And I'm not going to go over all the details here, but you can see here that we've now associated with all the anatomical components of cardiovascular disease, including aortic stenosis. And then we've also linked this with all the clinical phenotypes. And this measurement is now available in the USA for clinical use, particularly for patients that are intermediate risk that you're trying to risk stratify into a higher, lower category. And then I'll show you some data with this in some therapeutic studies when we talk about LPA-lowering therapies. Now, what does a plaque look like in terms of its OXPL and LPA component? So this is a thin cap fiber atheroma. You see the thin cap here. You see that there's a necrotic core, so this is kind of like the lava inside the volcano. And notice here that it's highly enriched in macrophages, very poor in smooth muscle cells. There are some ApoB in the necrotic core, but look how enriched it is in LPA, both in the fibrous cap and in the necrotic core. And notice that the OXPL in some of the same places, it's in the fibrous cap and in the core, but not necessarily exactly where the LPA is. So this is telling us that some of the LPAs don't have OXPL on them, some of them do, but the OXPL can also be formed through other pathways. And so this is kind of what happens to patients right before they come in with an acute myocardial infarction. We've been able to now link this to aortic stenosis, and this is a study of a meta-analysis of 4 studies in patients that have pre-existing aortic stenosis. And we asked the question, how does LPA and how does OXPL correlate with the progression of pre-existing aortic stenosis? If you look at them individually, they both predict progression. If you put them in the same model, notice LPA drops out and OXPL stays significant. I think what this is telling us is LPA is a genetic risk factor. It's the carrier, but you have a second hit and you generate a lot of oxidized lipids and they ended up on LPA, then it's actually more inflammatory. Now, there's an interesting biological correlate here that I'd like to take you through because this is part of the fun of doing science. You can actually do things beyond the immediate question at hand. So we synthesized the data on the evolutionary aspects of LPA and OXPL, and I just want to take you through this. So this is plasminogen. It has the 5 kringles. And if you look here, plasminogen has the 3 kringles that you notice here. It does not attach to LDL. It has a protease domain and activity. It binds fibrin, and it has oxidized phospholipids on it. And I don't have time to review that for you, but that's plasminogen. Now, if you look at ApoA that evolved for plasminogen, it appears to have had 4 evolutionary steps. The first one is, pardon me about that, okay, we can leave them all here at once, but the hedgehog has evolved to have plasminogen kringle 3, multiple copies, and to bind to LDL. A second event occurred in monkeys that then evolved by themselves kringle 4, and then in apes, they actually now accumulated kringle 5. But what's interesting is only human LPA seems to have any oxidized phospholipid on it. So that's very interesting evolutionary biology, and we have to eventually figure out what all this means in terms of its risk to humans. The other parts that I'll briefly go over is ApoB does not seem to explain the risk of LPA and CVD, and neither does venous thrombosis. And so it's, again, what is the components of LPA that are causing cardiovascular disease? So with that background, now we're just going to finish up in the last 7.5 minutes or so to go over how the field has developed to develop a therapy. And we talked a lot about Nobel Prizes here. A Nobel Prize was given for siRNA to Andrew Fire and Craig Mello, but not to antisense, which is interesting, which came before. I'd be curious to see why that was the case. But nonetheless, this is what we have. This really started the field for RNA therapeutics. And there are 2 components of this. Antisense is a single strand. It's modified DNA. siRNA is modified RNA. It's double-stranded, but only the antisense strand has a physiological drug effect. And so in terms of LPA, our initial idea was to disrupt the production, the assembly of the particle. And we use mipomersen, which inhibits ApoB, and we tried to disrupt the assembly of this particle, and it was successful. What you see here is that the LPA levels in these transgenic mice go down, and you take them off the drug, it go up. The problem was the liver kept making free ApoA, secreted it, and it had its OXPL on it. And we thought, maybe that's not a good idea to disassemble it or prevent its assembly and have ApoA free floating, which is smaller and might bind to the vessel wall and get cleared into the vessel wall. So we said a more elegant way to do this is to actually go and inhibit ApoA, which is what we did. And this is kind of what started, I think, the field for RNA therapeutics for LPA lowering. So now we have about 10 drugs being developed, maybe more, for Lp(a). So let me just take you through a few of the studies and where we are in the current state of affairs. Pelacarsen is in phase 3. It's an antisense. It lowers LP about 80% for the phase 3 dose. Some of the phase 3 doses are not disclosed, so it's a little bit of an estimate about how much is going to happen in phase 3 versus the higher doses that are given in phase 2. We have olpasiran, which is an siRNA, and lepodisiran, which are potent drugs. They're in phase 3. Zerlasiran is in phase 2. All of these reduce LP 90% or more. We have 3 oral assembly disruptors in the clinic, and then multiple gene editors that our folks are working on. Some of these don't have data, that's why you don't see it here. So now there's an additional benefit to lowering LPA, which is it lowers the 2 kinds of oxidized phospholipids that we can measure, but it also lowers ApoB and LDL. It doesn't do this directly. The hypothesis that we've come up with is we know that LPA clears slowly, about 3.5 days. If you take the ApoA off of it, it's going to clear about a day faster. So probably what's happening here is that you have less competition for the receptor and your LDL can clear faster. So you get this additional benefit of lowering the LDL a modest amount. Now, besides that, lots of credit to Jeff Kroon and Eric Strohs for doing many biological studies. There are several papers now showing that with this LPA lowering, you have less monocyte chemotaxis, a reduced pro-inflammatory state of those monocytes, through a variety of pathways. And so there may be some initial biological effects that are very acute and very early in the atherogenic process that relate to inflammatory monocytes. Here's an example of olpasiran and its kinetic or pharmacodynamics. Notice here that these drugs are very potent and they come back to baseline very slowly. After the last dose, it could take 3 to 6 months for the level to come back towards baseline. This is lepodisiran, which is even more potent, and you can see here that you can achieve every 6-month dosing with this drug with appropriate doses. So it's going to be very exciting to see how that LPA lowering translates to clinical benefit. Now, we've also accumulated lots of data with oxidized phospholipids in some of these drugs, and notice here that these are very potent drugs to lower OXPL, from 88% to 92% on pelacarsen, olpasiran. We have some data with lepodisiran, or there will be data with lepodisiran, but you see here the muvalaplin data. So we don't know how this is going to translate to clinical outcomes, but hopefully these will be measured in the phase 3 studies, and we can kind of see the relationship of these variables to LPA lowering. So the test of the LPA hypothesis is as follows. This is the distribution of LPA. Notice it's right shifted. Most people have low levels. And then there's a population that we mentioned, 20 to 30% have high. The trials are going to put patients in this red zone. And because the drugs are so potent, they're going to lower LPA into the green zone. And this is different than development for LDL cholesterol reduction because it's taken us 40 years to get the Ls down under 70. Here, all of the drugs are going to get the vast majority of patients into normal levels. So we're going to know right away whether these drugs work, and the LP hypothesis will be tested up front. Now, for those of you that haven't seen it, the LP Horizon data just came out, and it's worth pointing out who these patients are going to be in the trials. So let me just take you through this briefly. Notice they're fairly young. They're under 60 years of age, even though they've had MI, stroke, PAD. The mean LPA level is going to be 108 milligrams per deciliter, which is maybe higher than might have been anticipated. In animals, it's 236 nanomoles per liter. The patients are extremely well treated. 77% are on high-intensity statin, 57% are on ezetimibe, and 10% are on PCSK9 inhibitors. and the mean LDL going in is 65 milligrams per deciliter. So hopefully we've removed a lot of the LDL in this equation, and now we just have the LPA to deal with. So the three trials are fairly similar in design, but they go from very sick patients in Horizon to include high-risk primary prevention in the lepidosiran trial. The endpoints are fairly similar, except the Ocean-A study does not have CVD, it has CHD, so it does not include stroke and PED in its endpoint. And finally, there's actually LPA Frontiers CAV study, so there's an aortic stenosis trial ongoing that's now actively recruiting. If any of you have those patients, we'd love to hear from you to put them in the trials. So finally, I want to finish up and suggest to you that we're going to have a lot of patients to take care of, and we have lipid clinics, but there's another paradigm that I am suggesting here, which is we should consider having LPA clinics. And I started an LPA clinic in 2014, and I wrote this paper with Eric Strohs, and it goes over the rationale why you should have these patients in the clinic and why are they different than, say, other patients. Although they can have overlapping disorders, they have to have high LPA to come to this clinic, and there's a lot of issues we deal with. What do you do right now before you have an active therapy? What do you do with their families? You also have patients that come in with aortic stenosis, various thromboses that you have to deal with. A lot of them are young, have coronary calcium, and if you'd like to read about that concept, and if you'd like to consider starting that clinic where you are, I think you're going to find this extremely rewarding. So with that, I want to thank you very much for listening, and thank you very much for the British Society for the invitation, and we look forward to the next year or so until all the readouts. Thank you very much.
Sam, thank you very much for this wonderful talk. Oh, he's escaping. Catch the flight. Okay, good, then. Question? A very quick one. Is someone from the audience who has a question? Please line up, otherwise.
Sorry about that. I didn't realize you were taking questions. Happy to do it.
Sam, could you imagine that free ApoA, like as we see it from Muvalaplin trial, is still atherogenic?
Well, that's what I was suggesting. It's a hypothesis, but I think the key with the oral disruptors is we have to figure out where the ApoA is going when you disrupt a particle, because the drugs don't work to lower LPA on their own, right? What they're doing is they're disrupting the assembly, and then we expect something else to lower the level. Now, what is that something? It could be that the ApoA is getting degraded in the cell, in the hepatocyte. But if not, it's coming out, and then it's going to go maybe bind to an LDL receptor, maybe to a VLDL receptor, a plasminogen receptor. It can get degraded by elastase as it go into the urine, or it could theoretically bind to the endothelium and get taken up in the vessel wall. And so we really need to figure that out, I think, carefully to understand that mechanism and the implication of that, before we do large-scale studies.
But do you know whether the free ApoA has OXPL?
It does. It has lots of it. In fact, in some studies, it has most of it.
Okay, then it would be important that it escapes soon.
Yeah, exactly.
Okay, good. Other questions? There's one.
Sam, Scott Murray from Liverpool. I'm over here. Just to say, two questions. How do we stop humans from aggregating oxidized phospholipids? And two, is there any benefit to Lp(a)? We've obviously carried this forward in 20% of the population, and any problems with reducing that?
Yeah, those are great questions. I think we've learned that antioxidants, at least vitamins, cannot prevent oxidation very well. Because the kinetics are like 6 orders of magnitude faster than, say, vitamin E can prevent that. The other approach that we've taken, and Joe Wissam has led this effort, is to use antibodies to bind the oxidized phospholipids so they don't interact with receptors that can cause inflammation. That works very well in animal models. We now have data on a variety of phenotypes: atherosclerosis, ischemia of perfusion injury, MASH, the brain, pain syndromes. And so we do have an effort to look at that hypothesis, whether lowering LPA, inhibiting OXPL, or both are going to have differences. We're not there with patients yet, but maybe that could be something in the next few years that we can get some information from.
Okay, I think we don't have time for further questions. I'm sorry about that. Sam, thank you very much, and we are moving on.
Okay, we can now move on to the next speaker, which is Jaimini Sigla from Imperial College, London.
Thank you very much. So my name's Jay Segler. I lead the lipid service at Imperial College Healthcare, and I've been asked to talk today about should we do cascade screening for Lp(a). These are my disclosures. And so over the next 20 minutes or so, I'll touch on Lp(a), cardiovascular risk, and heritability. We'll talk about some of the screening approaches that are available to us and what the guidelines tell us. We'll discuss some of the benefits of cascade screening and what the evidence shows us so far. We'll talk about some of the challenges here, and then we'll conclude. And so Sam has already told us about this particle, this Lp(a) particle, and we know from that recent biobank study, UK biobank study, that on a per particle basis, this appears to be 6 times more atherogenic than LDL. And we know now that it's an independent risk factor for cardiovascular disease, and I've written here that elevated Lp(a) is linked to MI, ischemic stroke, and aortic stenosis. But I want to be clear that this elevation, this is not a binary thing. This risk is a continuum. So we've got to always think about that because, the guidelines and when we think of thresholds for screening will be man-made thresholds. But in terms of risk, this is definitely a continuum. And in terms of the inheritance, this is inherited in an autosomal codominant manner. So the predominant marker that determines your Lp(a) levels are the number of Kringle 4 type 2 repeats that you have, and your levels really are determined by what mum's levels are and dad's levels are. So what are the screening approaches? Let's look at the guidelines. What do the international guidelines tell us? And of course, the most prominent guideline that we have is the EAS guideline, and this tells us that Lp(a) should be measured at least in every adult's lifetime. And this is really to identify those with the highest Lp(a) levels, greater than 430 nanomoles per litre. And that's to try and identify those with a cardiovascular risk equivalent to FH. And then if you look at the abstract of the EAS guideline, the wording around cascade testing is slightly less strong. It says cascade testing has potential value in FH or with a family or personal history of a very high Lp(a) or premature cardiovascular disease. Then we look at the NLA guideline, the National Lipid Association, and this was updated last year, and it says that we now have sufficient evidence to support a recommendation to measure Lp(a) once in every adult's lifetime. And it also recommends cascade screening of first-degree relatives with high Lp(a). And the Canadian guidance also suggests once in a lifetime. So in the UK, we took a slightly different approach, and this was a guideline that we developed in 2019 now, so 5 years ago. And I want to just make you understand that this was in the context of a health system whereby most adults get their first LDL cholesterol measured at the age of 40, okay? So we felt that it was best placed at the moment for Lp(a) to be measured in specific cohorts of people. And I want you to draw your attention to this group, which was first-degree relatives with raised Lp(a) levels of greater than 200 nanomoles per litre. But despite these national and international guidelines, we know that actual testing rates are very, very low. And this study from California, 5.5 million adults across these academic health systems, there was only a testing rate of 0.3% in the population. And there's a similar study that came out last month in the Cleveland Clinic showing similar rates. And similar studies from Israel, Turkey, Germany, it goes on. And we did a survey in the UK recently, and even within specialized lipid services in the UK, 20% of services reported that they had no access to this test. So we've got a long way, we've got a real sort of gap here. The guidelines are telling us one thing, but the implementation is something completely different. So We've talked a little bit about universal screening. This is what a lot of the international guidelines are telling us to do, once in a lifetime in everyone. We've talked about selective screening, so looking at specific cohorts of patients. And then these are not mutually exclusive and can be combined with cascade screening. And this is already, as you've seen, is being recommended in our guidelines. So why would we consider cascade screening for Lp(a)? We've talked about its strong heritability. We've also discussed about how common it is. The identifying these at-risk relatives early seems like a pragmatic thing to do. And there is potential for early intervention. So, sorting out lifestyle, putting these people on statins to potentially lower their LDL, all sounds like a good thing to do. So what are the benefits of cascade screening for cascade testing for Lp(a)? I'd like to just review the evidence with you that we have. And this is a handful of studies that we have. They are quite small, but they are important. So I will spend some time going through them. So in terms of the cascade testing, the potential benefits, early risk stratification, family education, and then targeted lifestyle or pharmacological intervention, potentially with the future therapies that Sam has alluded to. But what is the evidence? Let's have a look. So the first study to really look at cascade testing for Lp(a) and really think about the feasibility of this was defined as greater than 50 milligrams per deciliter. And what they found was that if you had a proband who had elevated Lp(a), you needed to screen 2.4 relatives to identify one with Lp(a) that's raised. Whereas if you looked at probands with lower Lp(a) levels, you had to screen way more relatives to identify one with a raised Lp(a). And this seems like common sense, but it's important to get this evidence. And they went further, and importantly, they also looked at the impact of this Lp(a) on cardiovascular risk. And the hazard ratios here for a CV event or death at 5 years is displayed here. And you can see people with FH alone, these relatives, had a hazard ratio of 2.4. An isolated Lp(a) was a higher hazard ratio than FH alone at 3.1. And then if you had both, so double trouble, that was a hazard ratio of 4.4. This is really important data. So the data from SafeHeart was in adult relatives. What about children? What about adolescents? So this is data now from Gerald Watts's group, and this was conducted by Wan Lo, who's now in Singapore, and she's doing some amazing work on Lp(a) education programs through her LILAC study. And she looked specifically at children. So she looked at 103 children or adolescents tested of 66 adult probands with FH, and they had their Lp(a) levels tested. Now, her threshold was slightly different. So in the proband, the elevated Lp(a) was greater than 50, whereas in the relatives, she was looking at a threshold of greater than 30. And you can see that if you had an FH proband with an elevated Lp(a), you needed to test 2 to identify one with an elevated Lp(a) there. Whereas this was a much larger number needed to screen if the FH proband had a lower Lp(a). And this was, as mentioned, in a child population, median age of 12. So both of these studies I've shown you are in the context of FH cohorts having Lp(a) screened at the same time. So what about non-FH cohorts? And this is a further study from Gerald Watts's group. So this was cascade screening, also in Western Australia. They looked at 83 probands. 43% of these patients had familial combined hyperlipidemia, and 34% had common hypercholesterolemia. And they all had an Lp(a) of greater than 100 milligrams per deciliter. And for these 83 probands, 182 relatives were tested. And here you can see that if your proband had an elevated Lp(a) of greater than 100 milligrams per deciliter, you needed to test 3 of the relatives to identify one with an Lp(a) of greater than 100. And then finally, this UK Biobank cross-sectional study that's come out a couple of years ago. This isn't doing cascade testing through the service. This is cross-sectional data, but obviously this allows much, much larger numbers. So it's important in its own right. And here they looked at Lp(a) measured in pairs of first-degree relatives, 20,000 pairs, second-degree relatives, and then they compared this to random pairs of unrelated individuals. And you can see the number needed to screen here. So if you've got first-degree relatives being tested, you only needed 2 to be screened to identify someone with an elevated level. Second degree is slightly higher, and then obviously unrelated people is much, much higher. And here you can see this beautiful concordance between the Lp(a) of the index participant and the first-degree relative. So we've seen some evidence here that, that cascade screening would really be of benefit to our patients. Let's now look at the challenges. So one of the issues is lack of clear treatment pathways. How do we manage this in clinical practice? What are the thresholds that trigger cascade screening? What age thresholds should we be looking at? What should we do with the result? How do we explain this to our patients? And how exactly should it impact clinical management? And who does it? Should this be done by general practitioners? Should this be done by lipid services? And so there's a number of questions here. And firstly, just to look at the Lp(a) threshold, I find this really difficult. As you've seen in the studies, various thresholds have been used. And if we look at the EAS guideline, which is an amazing, excellent guideline, but even here, full of clarity, we see some ambiguity. So it's stated in the guideline that cascade testing for high Lp(a) is recommended in the settings of FH, family history of very high Lp(a), and personal or family history of ASCVD. So what is very high Lp(a)? Why is very in brackets? Is this high Lp(a), or is this very high, or is it both? And when we look at the definition of very high, this here is discussed as the 95th percentile, which would equate from the Copenhagen data here at around 200 nanomoles per liter. Whereas here, very high Lp(a) is more like 430 nanomoles per liter. So which is it? What should we be using? And then if we think about the age threshold, at what age cutoff should we think about starting to do cascade screening? And again, we look at the National Lipid Association guideline. This is from their patient leaflet. You can see this is the wording that goes to the patient. So if you have elevated Lp(a), your first-degree family members, so parents, siblings, and children, should be tested. They should be tested as soon as you are able for both adults and children. So what do I say to my patient, my 29-year-old patient who has very high Lp(a), and she has a 2-year-old child? Does the 2-year-old child need Lp(a) testing? So lots of unanswered questions here. Let's now think about cost-effectiveness consideration. And there, I've put limited cost data. And we've seen a glimpse of some really promising cost-effectiveness data yesterday on the EAS stage. And we really look forward to seeing that published, because I think that will be the first cost-effectiveness data we have for cascade testing. What about comparisons to FH programs? I mean, we have a great infrastructure for cascade testing for FH, and we have good evidence and cost-effectiveness evidence for this. But in terms of workforce, I know certainly in the UK, in London, when we interrogate our genetic lab, we actually do, at the moment, 6 index cases for every 1 cascade. We've got it the wrong way around. We're clearly not doing enough cascade testing for FH. So where we're struggling with FH, do we then move resources to Lp(a)? We need to really think carefully about the workforce here. And then, of course, potential cost-benefit with these emerging therapies. Will that move the needle? And then public health considerations. So we've talked about population screening versus cascade screening. Are there equity concerns here? I mean, certainly in the UK at the moment, a lot of Lp(a) testing is really driven through the private sector, through well checks that are being done. The test then, the patient gets a report with a very high Lp(a). It goes to a GP who doesn't know how to necessarily interpret it, and then the patient comes to us. And these are very eloquent, affluent patients. So are there equity issues that may fall out from this? And then finally, I think the role of healthcare systems, we really need to be clear within our own systems as to how we organize cascade screening in a structured way. In terms of ethical considerations, we need to think about consent, privacy, in terms of our family-based genetic screening, and whose duty it is to inform relatives. Is it the patient themselves? Is it the onus on them? Or is this cascaded through the clinics? What about impact on insurance premiums? We should think about this. Certainly in the UK, we have a moratorium on sort of hiking insurance premiums for predictive genetic testing. But in practice, I've seen patients who can't get life insurance when they want to get a mortgage for a house. So, we've got to have these transparent conversations with our patients. And then, of course, the psychological impact of genetic risk. So, to conclude, I think cascade screening is hugely promising, and we have these fantastic feasibility studies. They are small, but they are very important, and so far they certainly suggest that this is an efficient approach. And from a pragmatic perspective, Lp(a) has high heritability. Early risk identification does have the potential for, starting treatments like statins and lifestyle intervention early on. There are challenges that we face, and I think we, should use this period really for readiness to develop our treatment pathways, to think about the psychological burden and how we best communicate these results to our patients, and we need to think about the robust infrastructure to do this. And we definitely need more research and health policy development, particularly around cost effectiveness as well, to further inform this. Thank you.
Thank you very much for the very informative talk. If you have any question, please come forward. Can I start with a very quick one? You have done a very nice overview of what's happening in high-income settings. What is your view of what we should do in low- and middle-income countries?
It's a great question, because I think there's very, very little access to Lp(a) testing elsewhere. And I think there's us as clinicians here, talking about the test, but we really need to talk with our laboratories to make sure that this test becomes accessible and also then reimbursable. So there's a huge piece of work that needs to be done, and particularly as Sam's talked about, the potential for new treatments coming along the line. If these trials are successful, all our heart attack patients, all our stroke patients potentially will have an Lp(a) test. So we need to think about workforce considerations for this.
Okay, thank you. Please.
Hi, Henry Ginsberg. Very nice presentation. And this may be pie in the sky, but as we now try to prepare for hopefully positive studies and moving forward, finding more people, we have to get better ways to unify the units, right? We have LDL cholesterol. We're starting to get ApoB in milligrams per deciliter, but that's not LPA in milligrams per deciliter, right? That's a particle. One is a protein. We need to get nanomoles per liter, whether it's a conversion factor or we finally get the assays that directly measure it. And we can then teach patients, but more importantly, physicians, how many particles of LDL there are, how many of them are really LPA, and then with that 5-fold difference in risk, they can equate two parallel risk factors as to which one is more important at the moment and which one maybe they should go after first. Maybe lowering LPA would be, before you lower LDL past a certain point, would be the way to go. Yeah. But with 3 sets of units, we're really way behind on the education front.
I completely agree with you, Henry, there, because I think, that is a huge source of confusion. And I can think of, 20, 30 times where I've had a referral for an Lp(a) high Lp(a) patient to my clinic, but I don't know if it's high because I've only got the number. I haven't got the unit associated with it. And it's highly frustrating. And I think we do need to do more in terms of advocating nanomoles per litre. I know that the NHLBI have done some work and some, in recommendations. Certainly have the EAS and our UK recommendation is definitely for nanomoles per litre. So we really need to move to one unified unit. Yeah.
There's also no reason at all to have ApoB, which is measuring the protein, not the particle, as milligram per deciliter. There's a conversion factor. It's about 20. And so all the ApoB measured could be nanomoles per liter, and the LPA could be nanomoles per liter, and then people can, be educated as to what that means for risk.
And I think we do need to do more work with our labs to ensure that the units and also the actual assays that are being used, that they're using are fit for purpose and traceable.
Okay, quick question, quick answer.
Oh yes, Volker Schettler, Göttingen, Germany. Thank you for your wonderful talk. My point is, when you advise to measure Lp(a), because this questions remains open. Actually, we have heard so much influence of the environment. Actually, we have heard a lot of risk factors beyond cholesterol, and the question remains open: when should we measure Lp(a)? Because all these factors getting in the human beings and affect them. We have hypertension and so on. So actually, I would advocate for early measurement. What's your opinion?
I think, if you want to do a full cardiovascular risk assessment, then Lp(a) should be part of that to really inform your risk. So, there's several risk calculators now that incorporate Lp(a). So in an ideal world where money and access were not an issue, everyone should have it done, yeah.
But isn't it a major problem when we are doing the first risk factor profile at age of 40? We are talking here about prevention, and then we are starting to look at the people at the age of 40. This is way too late. So it has to be done much earlier. And of course, an Lp(a) and LDL measurement, this should be included.
Perhaps at adolescence, around about 18 and 20 years, perhaps earlier.
Yep.
Okay, thank you very much for your contribution.
So the next presentation is from Matej Mlinaric and is with the title Lp(a) Values in Children with Hypercholesterolemia.
Hello, thank you for the introduction. So I have nothing to disclose. So as already was stated, lipoprotein A is an important risk factor for cardiovascular disease and also quite frequent. As was already told, 20% of the general population has elevated Lp(a) values. In Denmark, the threshold was stated as 42 milligrams per deciliter or 88 nanomoles per liter. In children, in Lebanese and Finnish study, the threshold of 30 milligrams per deciliter is reached in 15% of all the population. So in children with familial hypercholesterolemia, in the Netherlands, they have shown that 31.5% of probable FH children, that means that they don't have a genetic variant that causes FH, had already Lp(a) above 50 milligrams per deciliter. And in children in Italy with familial dyslipidemia, 21.5% of children with cardiovascular disease had already Lp(a) levels above 98 milligrams per deciliter, and in those without CVD, the risk was a little bit lower, so 7.8% had Lp(a) levels above 98 milligrams per deciliter. So what about in Slovenia? In Slovenia, we screen for familial hypercholesterolemia, and in the second part, where the children come to our outpatient clinic, we also include a lipid panel that includes Lp(a), and these were included in our study. We excluded children that had treatment medication prior to the first visit or concomitant diseases. So we divided the population study in 3 non-overlapping subgroups. The definite FH group was with children that had a confirmed FH-causing variant in the genes of LRR, ApoB, and PCSK9. The definite on FH were siblings of those, but didn't have a FH-causing variant, and possible FH were children that were sent with universal screening that didn't have a disease pathogenic variant or had likely benign or benign variants of unknown significance. So that we included at the end 1,418 children. The median age was 6.34. The 75% of them were female. In the definite FH group, 363 children were included. That means 25.6%. In the possible FH, 1,014 children were included. That means 71.5%. And in a definite non-FH group, 41 or 2.9% were included. The LPL values range from less than 10 milligrams per deciliter to 224 milligrams per deciliter. The cholesterol representation is presented in the table down in the slide. So total cholesterol was 5.6, LDL cholesterol was 3.6, HDL cholesterol was 1.5, and triglycerides were 0.8. So the distribution differed already when comparing those 3 groups. The possible FH group had the highest percentage of LPA values above 30 milligrams, 50, 100, and 150. 34.9% had already LPA values above 30 milligrams per deciliter. In a definite FH group, the number was a little bit lower, 25.1%, but it's still higher than in the Finnish and Lebanese studies on healthy children. So LPA as a particle mimics LDL cholesterol, and we wanted to see the correlation with LDL cholesterol. There was a slight correlation in all of the subgroups, but only in the possible FH group it was also statistically significant. But the genetic variants for FH moved the LDL cholesterol to the right, and therefore if we compare all together, then the trend line becomes quite horizontal. So in every child we measure also the carotid intima media thickness and convert it to the standard deviation score based on data provided from Dr. Drolet. And also we measure high sensitive CRP, but we didn't see any differences at baseline. But we have seen some trend lines. So in possible FH, the carotid intermediate thickness standard deviation score correlated positively with body mass index standard deviation score, and high sensitive therapy, CRP, positively correlated in a definite and possible FH group with triglycerides and negatively with HDL cholesterol. So, because our screening includes also the family history of cardiovascular disease in the first step, we can see a lot of positive family history in all the subgroups, but the highest was present in the definite FH group. In the possible FH group, it was a little bit higher, but also almost half of the children had a positive family history for cardiovascular disease. In a definite non-FH, the number was around 40%. So in every child, we also measure those modifiable risk factors. We didn't see any differences in body mass index or blood pressure between the groups, but already you can see that quite a large proportion has those risk factors. So obese were around 8% of children. Systolic blood pressure was elevated in 5% of children. Diastolic blood pressure was elevated in 10%. So as expected, the LDL cholesterol percentage above 3.5 millimoles or 135 milligrams per deciliter was mostly elevated in the group with definite FH because of the FH pathogenic variants. Even after correction for the LPLA 30% of the mass, the percentage stayed very high, 88%. But in possible FH, if we exclude LPA from the LDL cholesterol value, still 30% of children have elevated LDL-C. So our next question was, could we screen for high LPA in our setting that we would find everyone? So as we previously stated, the prevalence of familial hypercholesterolemia in the general population is around 1 in 313 individuals. The prevalence of very high LPA levels above 110 milligrams per deciliter was stated that it's 3 times more prominent, so 1 in 100 individuals, and the prevalence of high LPA levels above 30 milligrams per deciliter is approximately in 1 in 5 individuals. So in our study, we have found the same number almost of those with LPA above 30 milligrams per deciliter and with confirmed familial hypercholesterolemia. But in the familial hypercholesterolemia, you have to take into account that there are 25% of children that also have high LPA that are not mentioned in the previous group. So by measuring LPA, we just, in people with hypercholesterolemia or children with hypercholesterolemia, we miss a lot of cases. So this wouldn't be feasible to find all of the patients. So to conclude, measurements of LPA in FH screening are important. LPA already in children is an important cause of clinical phenotype of familial hypercholesterolemia. Children with high LPA have other modifiable CVD risk factors that can be addressed. Screening for LPA just in the setting of hypercholesterolemia is not enough to find all people with high LPA, and everyone should have LPA levels measured in his lifetime, as was said previously, and as early as possible. So, acknowledging, I would like to thank the EIS for support in the form of investigator fellowship, and also all my colleagues and the patients.
Thank you very much that you introduced the program you have in your country. Is there anyone in the audience who have a quick question? Yeah, I think we have here now the different situation, very early screening, and I think, in my opinion, an LDL should always go hand in hand with an LPA measurement, especially this is a big chance, because when we are talking to people with lived experience of high LPA concentration, if they know it quite early, they tell us that it is also an advantage to know it early, because then you are not taking up the bad life habits, maybe, hopefully. And when you measure it with the age of 40 and you have already bad life habits, it's not easy to get rid of them. If someone tries to lose weight and all this stuff, it's much better to not gain weight in the young years. Yeah. Okay.
I agree.
Yeah. Thank you very much. And quick question. Yeah.
Thank you very much, Nigel Capps from the UK. Have you up-cascaded to any parents or grandparents from the children?
So for now, we just suggest parents, but yeah, we don't systematically cascade screen for high LPA, but yeah, we cascadely screen for familial hypercholesterolemia. But yeah, those with familial hypercholesterolemia, we are more prone to suggest that they also measure LPA, but yeah, for all others, it's still in development. But we suggest the parents that they should have an LPA measured.
Yeah, thank you very much.
For me to be here today, and I'm going to talk about our recent work, the association of lipoprotein A with coronary atherosclerotic plaque characteristics detected by 3-vessel OCT in patients with acute myocardial infarction. So here's my disclosure. The study was founded by Beijing Novartis Pharmaceutical Company. We all know that elevated Lp(a) is an independent risk factor for cardiovascular disease, and it promotes atherosclerosis through several mechanisms, such as pro-atherogenic, pro-inflammatory, and pro-thrombotic mechanisms. And prior studies using CCTA has identified that elevated Lp(a) was associated with low attenuation plaque, and some small sample size OCT study also found that patients with elevated Lp(a) had more prevalent corporate TECFA, which is thin cap fibroatheroma. It is a very typical vulnerable plaque in the intravascular imaging studies. And what about non-corporate lesions? And we know that non-corporate lesions account for about 15% of future events, and high-risk non-corporate lesion leading to recurrent events often had these features such as small luminaria, thin fibrous cap, and large lipid core. So until now, direct evidence linking Lp(a) to non-corporate lesion across the whole coronary tree remains limited. So what's the relationship between Lp(a) and non-corporate lesions is really a question. So the present study, we aim to investigate the association of Lp(a) with pancoronary plaque characteristics by using 3-VES OCT in patients with acute myocardial infarction. We know that OCT is a high-resolution imaging modality, and it can visualize the microstructure of coronary artery plaque. And also, 3-VES OCT can enable us to draw the whole picture of coronary artery tree. So this is a retrospective single-center observational study including 1,005 AMI patients who underwent 3-vessel OCT imaging after successful intervention between 2017 to 2021. All patients were divided into two groups according to the baseline lipid Lp(a) level, and we analyzed all the non-corporate lesions of these patients. So baseline serum samples were obtained and stored at -80, and Lp(a) were measured using Rachi diagnostic kit. And Lp(a) level of 75 nanomole per liter or higher were considered elevated. We measured all the 3 epicardial artery and using the OCT, and these are some representative OCT images of high-risk plaque characteristics such as plaque rupture. We can see there is a rupture cavity, and this is the thin cap fibroatheroma. We can see that it is a very large lipid pool with overlying thin fibrous cap, and this is the macrophage. These are all high-risk plaque features. The primary endpoint of this study is the non-corporate thin cap fibroatheroma. So let's see the results. Lp(a) was elevated in about 15% of all AMI patients, and with a median value of 19 nanomole per liter. So this is the baseline characteristics. The average age of all enrolled patients were 57 years old, and 75% were male. And risk factors were comparable between the two groups. Here we can see the labs. Patients with elevated Lp(a), they had higher levels of cholesterol. And we analyzed more than 4,000 non-corporate lesions in this study. For angiographic features, we found no significant difference between the two groups, including the lesion location and QCA data, such as the stenosis, diameter stenosis, and lesion length. There is no significant difference. Let's see if OCT can provide any new findings. First, this is the patient-level analysis. The pullback length of non-corporate lesions were comparable between the two groups, and the median number of non-corporate lesions were 4 lesions per patient. And we can see that patients with elevated Lp(a) had higher prevalence of plaque rupture, thin cap fibroatheroma, macrophage accumulation, and macrochannels. And we know that these features are all vulnerable plaque features that are associated with progressive atherosclerosis and recurrent adverse cardiovascular events. So we can know that Lp(a) are related to plaque vulnerability. So next is Next is the lesion level analysis. It is also show that patients with these lesions with elevated LPA had higher prevalence of plaque rupture and macrophage accumulation. So to identify the association LPA and non-corporate lesion plaque features, we analyzed the logistic regression analysis, and the model includes the clinical risk factors and also the laboratory tests. And after adjusting for these covariates, we found that the elevated LPA was independently associated with non-corporate plaque rupture. So with adjusted OR of 1.19, and elevated LPA was also independently predicted the non-corporate TECFA with adjusted OR of 1.68. To conclude, in patients with AMI, Lp(a), the elevated Lp(a) indicated increased level of pancoronary plaque vulnerabilities, and elevated Lp(a) was independently associated with non-corporate plaque rupture and TECFA. So the awareness of elevated Lp(a) levels in patients with AMI may therefore support decisions on clinical management. So now we know the association between Lp(a) and the pancoronary plaque characteristics. I think next step, there's still a question. If lowering LPA can stabilize the high-risk features, I think it's still a question. And I believe future studies will answer this question. Finally, I would like to thank all patients and colleagues. And I sincerely want to thank my teacher, Professor Bo Yu. And that's all for my presentation. Thank you very much for your attention.
Thank you. Please.
Henry Ginsberg, very interesting data. I'm a little confused about one point, the plaque rupture.
Yeah.
So you have a culprit lesion in patients who are presenting with an acute event.
Yes.
And so then you're looking at non-culprit lesions.
Yes.
So those ruptures, they were healed ruptures.
Yeah.
And so these patients had had an event that wasn't clinically identified. We know that happens. Is that your thought on that these patients actually had prior events?
Oh, yes, that is, thank you very much for this important and interesting question. We know that some plaque rupture, they will cause thrombotic events, maybe acute coronary syndromes, but some plaque rupture may be silent, and most of them are non-corporate plaque ruptures. So in this study, we found that there are some non-corporate plaque rupture. So that's our findings.
So if I might just extend, that's so interesting and maybe a little counterintuitive, since we think of LPA as being prothrombotic, and we think of it as a risk factor that may cause small ruptures and small clots to become large clots.
Yeah.
But you found more small ruptures that didn't cause an obvious event.
Oh, yes.
That's very interesting.
Yeah, a very interesting point. I think we should study more in this point. Thank you very much.
Okay, perfect. Thank you very much for your contribution.
Thank you.
The next talk is by Kaloyan Dakov from the United Kingdom here, and it's about lipoprotein A as an ApoE containing particle enriched in triglyceride species associated with incident cardiovascular disease.
Thank you very much. Thank you very much for the opportunity to present here, and also thanks to the speakers before me who introduced Lp(a) so nicely, so I can save some time. So I have nothing to disclose. So you have heard a lot about lipoprotein A. For the purpose of this talk, I would like you to keep in mind that lipoprotein A, the current broad understanding, is that this is an LDL-like particle with a lipid core and this very large apolipoprotein called apolipoA that's attached to it. We don't know what the physiological function of this particle is, and we also don't fully understand the pathophysiology, especially in relation to LDL, although you have heard very nicely that Lp(a) may be much more atherogenic if we normalize the particle numbers. So I'm going to try and convince you today that we need to understand the the composition of Lp(a), proteins that interact with the particle, so we can decipher these unanswered questions. So there have been studies on the proteome of Lp(a), and they have identified a diverse set of proteins on the particle, and virtually every apolipoprotein, as you can see in green, in this cluster there. Among them is also ApoE, which I'm going to concentrate on today. Why ApoE? There have been quite a few GWAS and population studies that have shown that variants in ApoE influence the levels of circulating Lp(a). This is especially true for E2, E3, and E4 variants. But what the mechanisms behind this level regulation are, we still don't understand. There's speculation that it may be related to the clearance of the Lp(a) particle because of the presence of ApoE on Lp(a). However, there is also kinetic evidence suggesting that ApoE may be important for production of the particle. Another reason why ApoE is interesting is a couple of observations we made when we tried to see what correlates to apolipoprotein in circulation and atherosclerotic plaque. So firstly, we looked into the UK Biobank. Circulating levels of about 3,000 proteins were measured at the time we did this analysis, and we correlated apolipoprotein to all the proteins, and to our surprise, the third most correlated protein was ApoE. This is regardless of the ApoE variant. In addition to that, if we look at the proteomics of an atherosclerotic plaque, so these are carotids and the enterectomies, and we look at what apolipoproteins correlate to apolipoprotein, the only apolipoprotein that consistently correlates with apolipoprotein, regardless also of the region of the plaque, we have cores and peripheries, is ApoE. And apart from ApoE, we also observed a few other correlations with other apolipoproteins that are related to triglyceride-rich particles, and you'll see a bit later why this is important. So our objective was to try and capture the genuine interactome of Lp(a), the proteins that are present on the particle, and also its lipid content. And our main goal was to preserve the endogenous Lp(a) particle and protein interactions by using methods that are gentle, that don't use high ionic strength or high speed. So we used immunoprecipitation in a one-step workflow, and also one-step workflow size exclusion chromatography. We also have a combination approach as well. The first thing we did is we established immunoprecipitation to pull down Lp(a) from plasma. This is very efficient, and we have performed proteomics of the particle that we isolated. This was the large proteomic study of purified Lp(a), and apart from the usual suspects that we identify on Lp(a), apolipoprotein, and ApoB, the most consistent apolipoprotein that was present in the particle was ApoE. We have also used different, technically speaking, different antibodies, different detection technique. This is a Western blot in this case. Different solid phase for the immunoprecipitation. We always detect ApoE on Lp(a). We also combined size exclusion chromatography with immunoprecipitation, and once again identified ApoE as part of the Lp(a) proteome. We have done a reversed approach as well. We pull down ApoE directly from plasma once again, and we co-immunoprecipitate apolipoprotein, as you see on this Western blot on the right. And finally, we have performed the first cross-linking proteomics of an isolated Lp(a). So this is an approach which uses a chemical cross-linker that will covalently bind proteins that are in proximity, and this allows us to construct these protein-protein interaction networks like the one you see on the right. This is from an Lp(a) rich fraction, and we identify proteins that interact with each other in a complex. We, of course, see apolipoprotein interacting with ApoB, but we also see a lot of non-LDL apolipoproteins present in the complex, including ApoE, which indirectly interacts with Lp(a), with ApoB and apolipoprotein. So this led us to conclude that ApoE is part of the core interactome of Lp(a), but whether it's important functionally, we needed to have a model to study this. So we switched to an in vitro model of hepatoma cells, and we have produced different cell lines that express apolipoprotein and also produce Lp(a) particles, which we have verified using different means. Once again, if we pull down Lp(a) from the secretomes of these particles, these are two different cell lines you see on the right. In both cases, you see ApoE being present on the Lp(a) particles, suggesting that they resemble the plasma-derived Lp(a). Then we use the knockdown approach to knock down the two main lipoprotein secretion pathways in these cells, the HDL and VLDL, by knocking down ApoA1 or ApoE. And what we have seen is a big reduction in the ApoB and also apolipoA that's released in the secretomes from these cells when we knock down ApoE, suggesting that Lp(a) is produced through an ApoE-dependent mechanism. We also use the pharmacological inhibitor, which inhibits the loading of triglycerides on nascent apolipoprotein B particles. And we have seen massive reduction in ApoB secretion together with a dose-dependent reduction in apolipoA, which has previously been seen by Marlis Koszczynski group in another context. So this link to ApoE and VLDL prompted us to do some lipidomics of the apolipoA particles, and we combined our immunoisolation with mass spectrometry-based lipidomics of both the particle and the plasma that's completely depleted of apolipoA. So the first thing that we have observed is that food intake doesn't have big impact on the LPA lipidome. The changes that we see postprandially on the LPA particle are not as pronounced as they are in plasma, as you can see on the right. But despite this, if we look at the LPA-depleted plasma and we see what else is depleted together with apolipoA, we found 35 lipid species that are depleted with LPA depletion, and 32 of these were triglycerides. Among those were some quite abundant triglycerides, like triglyceride 52.3 and 52.4, which were quite prominently present on the particle. And why are these triglycerides interesting? We look back at plasma lipidomics in two prospective cohort studies. They're also in different ethnicities, which you have heard is important. The first one is the Bruneck study we work a lot with in Caucasians, and the second one is the Strong Heart study in American Indians. They're in total about 2,500 patients. And a meta-analysis showed that there are only two triglycerides that are associated with development of coronary heart disease, and these are the two triglycerides that I've just shown you are present on the apolipoA particle. Just to conclude, I've shown you that apolipoA interacts with ApoE, that the secretion of the apolipoA particle is dependent on ApoE and likely occurs through the VLDL route in the hepatocyte. And I've also shown you that apolipoA carries triglycerides, and especially some species that are associated with cardiovascular risk. And this may partially explain the association between Lp(a) and atherosclerosis. And we are currently working on trying to understand the ApoE genotype effect on LPA production and uptake, and I hope I can update you on this maybe next year. So I'd like to thank all our collaborators, and especially the EAS Young Fellows program, thanks to which I'm here today. So thank you very much. Happy to take your questions.
Yeah, thank you very much. We have time for one short, quick question. Henry, you're in the pole position.
It's a very interesting data, and I think I know other groups of taking this path. But it raises two simple questions. One is, we've known for years, as you said, that ApoE4 is associated with higher LDL cholesterol levels. We would now know that those LDL cholesterol levels would have LPA in them. And so is that the association between E4 and high LDL? That's the first. The second is the triglyceride-rich particles. If there's heterogeneity, and the more triglyceride, the lighter that particle would be, and it would probably therefore fall into what we call remnants. And so as everybody's excited about remnants as atherogenic particles in people with hypertriglyceridemia, do they have LPA in what we call remnants?
Thank you very much. So the first question about ApoE variants, yes, it's also known that those ApoE4 carriers also have high Lp(a) levels, likely. I mean, this is not, I think there's no consensus about this, but there may be one reason why ApoE4 carriers are at a higher risk. But again, this is not understood. And in terms of the remnants, I don't know. That's an interesting point. I think so. Our methods here don't use the usual density-based separation. So we may have remnants with different sizes, and also our immunoprecipitation approaches obviously will pick those remnants anyway. So we don't have. I don't have information about this heterogeneity, but I know it will be quite interesting to see. Also in relation to the molar ratios of ApoE or triglycerides on different subpopulations of Lp(a) or ApoE carrying particles.
Yeah, thank you very much. And I think we have to move on.
And the next speaker is Peter Thomas from Denmark with a talk on Lp(a) and dementia.
Thank you so much for the introduction. It's now 5 o'clock. It's the second day of the conference. Thank you so much for sticking around and listening. Today I want to talk to you about lipoprotein (a) and dementia. And these are my disclosures. Now, dementia, including Alzheimer's disease and vascular-related dementia, is the 7th leading cause of death worldwide, and it's been estimated that about 1 in 3 individuals above the age of 65 now die with dementia. Furthermore, about 45% of dementia may be preventable partly through shared risk factors with atherosclerotic cardiovascular disease. And when we speak of atherosclerotic cardiovascular disease, nowadays, of course, we also have to talk about lipoprotein (a). As we've already had firmly established by our previous esteemed speakers, lipoprotein (a) is a genetically determined lipoprotein with a markedly skewed distribution in the general population, where we see that most individuals have very low levels, and some individuals have high levels. There's strong genetic evidence that elevated levels of lipoprotein (a) are associated with atherosclerotic cardiovascular disease, and this has prompted the initiation of 5 lipoprotein (a) lowering therapies that are currently in trials, and 3 of these are in phase 3 cardiovascular outcome trials. Also important to note is that the main genetic determinant of lipoprotein (a) levels is the Kringle4 type 2 number of repeats, where a low number of Kringle4 type 2 number of repeats is associated with a high lipoprotein (a) level. Now, why am I then talking about lipoprotein (a) and dementia in the same talk? Well, there have been a few previous studies that have indicated or sort of raised concerns whether low lipoprotein (a) levels might actually be associated with an increased risk of dementia. And this, of course, raises the concern that with these potent lipoprotein (a) lowering therapies, are we then actually increasing the risk of dementia? Now, when we're investigating a disease of old age, such as dementia, and we're investigating an exposure such as lipoprotein (a) that is associated with all-cause mortality, we have to be very careful in our statistical models to account for the competing risk of death. So what we did was we investigated the association of lipoprotein (a) with risk of Alzheimer's dementia and vascular-related dementia, and we accounted for the competing risk of death. To do this, we used the Copenhagen General Population Study, the Copenhagen City Heart Study, and also the UK Biobank for a total of about 570,000 individuals. Now, all of these cohorts are general population cohorts from the population of Denmark and from the UK. And in all of these individuals, they had a measurement of lipoprotein a at baseline, and they were followed in the national registers for information on dementia diagnosis without losses to follow-up. So what did we actually find? First, looking at Alzheimer's disease in the Copenhagen studies and in the UK Biobank, we graphed restricted cubic splines for the association between Alzheimer's disease and lipoprotein a, and we have lipoprotein a on the x-axis and the hazard ratio for Alzheimer's disease on the y-axis, with the restricted cubic spline graphs in red. And as we see quite clearly in both the Copenhagen studies and in the UK Biobank, we saw no clear association with lipoprotein a levels and risk of Alzheimer's disease. Moving on to vascular-related dementia, again we graphed the restricted cubic spline, and in the Copenhagen studies we saw no clear association with lipoprotein a levels, whereas in the UK Biobank you could see we saw a sort of a trend toward association with higher lipoprotein a levels. However, this was not statistically significant. Important to note is that in these restricted cubic spline models, we did not adjust for competing risks of death. However, we next calculated cumulative incidence plots where we did adjust for the competing risk of death. And when we do that and look at the risk of Alzheimer's disease, we have here on the x-axis the age in years, and on the y-axis the absolute risk of developing Alzheimer's disease in the Copenhagen studies and in the UK Biobank. And you can see that we find no significant association with higher lipoprotein a levels and a higher risk of Alzheimer's disease. What we do see is that there is a numerical higher absolute risk at age 80 years, but again, not statistically significant. Moving on to look at vascular-related dementia. First, in the Copenhagen studies, we see no significant association with higher lipoprotein a levels and higher risk of vascular-related dementia, whereas in the UK Biobank, we do actually see higher lipoprotein a levels do associate with a slightly higher risk of vascular-related dementia. However, when we look at the numerical absolute risk at 80 years, the absolute risk difference is small. Next, we looked in the Copenhagen studies, we looked at the Kringle-4 type 2 number of repeats in both Alzheimer's disease and in vascular-related dementia. And we looked at a lower number of Kringle-4 type 2 number of repeats, which we of course all remember are associated with a higher lipoprotein a level. And what we saw was that in the Copenhagen studies, a low number of Kringle-4 type 2 number of repeats associated with high lipoprotein a levels was associated with a higher risk of Alzheimer's disease, but not with vascular-related dementia. Now, if we are to sum up all of these results, we conclude that we found no evidence that low lipoprotein a levels are associated with an increased risk of dementia. And we cannot completely exclude that high lipoprotein a levels are not associated with Alzheimer's disease or vascular-related dementia. And we think these findings are clinically relevant given the 5 potent lipoprotein a lowering therapies under development, and our results at least indirectly indicate that lipoprotein a lowering may be safe with regards to risks of dementia. Finally, I would like to thank the EAS for the Young Fellowship, and also my funders, the Danish Heart Foundation and the Novo Nordisk Foundation, and of course all of you for listening. Thank you.
Thank you for your talk. Is there any question from the audience? If not, can I start with one? Do you see any link with the previous talk? Because we know that APOE is strongly associated with Alzheimer. In this case, you see no correlation. Can you comment on this?
Yeah, thank you. That's a great question. I was sitting in my seat thinking the exact same thing, that I should have included those results in the presentation. However, I figured I could only reach so much. We have looked at the joint association of high lipoprotein little a and ApoE genotypes in both cohorts, and we consistently find no clear effect modification of lipoprotein little a and ApoE genotypes on the risk of dementia, so that the association of lipoprotein little a with the risks of dementia is the same no matter your ApoE genotype. But yeah, it's really interesting.
Okay, perfect. If there are no more questions, we can move forward. Thank you very much.
So the final presentation is by Nathalie Arnold from Germany, and she will talk about Lp(a) and incident coronary heart disease in the community, impact of traditional cardiovascular risk factors.
Dear Chairperson, dear colleagues, it's a pleasure for me to be here and to present our results on behalf of all biomarker investigators. And we will talk about the impact of traditional cardiovascular risk factor on the association between increased Lp(a) value and incident coronary heart disease in the community. Here more disclosure information. We heard a lot about Lp(a) in this session, but there's still one point just to be repeated. It's also recommended by our current AS statement that the Lp(a) values should be considered in relation to traditional risk factors. And if Lp(a) level is not considered in risk assessment, the CVD risk might be severely underestimated. And you can see here that, for example, in a high-risk population, we are talking here about primary prevention. It's data from UK Biobank, and those with several risk factors and having high absolute risk, the risk for future events increase significantly with higher Lp(a) value. And for example, in those with Lp(a) of normal range of 60, for example, it's 25, and its risk goes up to 68 lifetime risk if the subject has Lp(a) above 350 nanomole per liter. And subsequently, if we can reduce the risk factor, we can also mitigate the Lp(a) associated risk. And we have clear data for this from EPIC Norfolk study and from the Kanazawa University Hospital. Both studies shown clearly that favorable risk profile compared to those subjects with not favorable risk profile, they also are associated with lower risk for future events despite the similar Lp(a) concentration. So we clearly, the clear statement for us, just we need to address risk factor, we need to initiate a lifestyle intervention, and we need to be persistent and motivate our patient to be adherent to lifestyle medication. But on the other hand, we have some uncertainty in the other end of this scale, in the subject with low absolute risk, because if they have no risk factor or only one, how can we mitigate increased Lp(a) risk in this population? And from public care, this population might be really important because they can generate a substantial number of events simply due to the fact that this population is really large. Here you can see our preliminary data from Morgan Consortia, 28 population-based cohorts with 230 individuals who, it's primary prevention population, subject were without CHD, without manifest CHD, and 55% of those subjects have either 0 or 1 risk factor. It means of 4 major modifiable risk factors. It means that 55% of those subjects are at low risk. So, important question to be answered here, whether individuals with very low absolute risk based on traditional risk factors, possess the same relative risk as individuals with elevated LP concentration and high absolute risk. And we address, therefore, the present aim of the present analysis was to assess whether the presence of traditional risk factors at baseline might have effect on the association between increased LPLA and incident CHD in general population, primary prevention setting. And we address this question within our biomarker consortia. We use for this analysis data from 66,500 subjects who were free of CHD at baseline. And we also stratified our population in accordance to presence of 4 modifiable cardiovascular risk factors at baseline: hypertension, diabetes, hypercholesterolemia, and smoking, and combined 2 groups. Very low risk group having 0 or 1 risk factor in baseline. It was about 42,000 subjects. And a second group was at increased risk, having 2 or more risk factors baseline. It was 25,000 subjects approximately. As outcome, we use the incident CHD. And we follow up, the follow-up of this subject was about 10 years, and during these 10 years, we have 3,500 events, and of course, if you can see here, the event rate in a low-risk population is lower than in the subject with higher risk. LPA was measured by Abbott assay, just as unfortunately was a mass assay in milligram per deciliter. And for this analysis, we use LPA cutoff of 90 percentile, which was in our study about 33.2 milligram per deciliter. And from statistical analysis, we use fine-gray competing risk adjusted models with several levels of adjustment. We calculated 3 different models. So here you can see the baseline characteristic of our study participants, and as expected, lower risk group was younger. There were more female participants in this group, and also interestingly, they had a higher level of education. And as expected, they have lower risk profile compared to subjects having 2 or more cardiovascular risk factors. And the first step, we just focus on absolute risk, just to be sure that we are in line with previously published study from UK Biobank or, for example, EPIC Norfolk study. And again, as expected, subjects with 2 and more risk factors in baseline have high absolute risk, and higher LPLA value also could modify the risk. And very important, the second part of this slide, where we also assess absolute risk independence in 2 groups, low and high risk group, and we see that despite having similar LPLA values above 90 percentile of LPLA distribution, the absolute risk was 3-fold higher in those with 2 and more risk factors. However, what we did what we wanted to do differently in this study, we wanted to shift the attention from absolute to the relative risk, and here you can see our main results. Showing it's sorry, just slide is very busy, but you see the 3 different models. It's the regression models, and this the third models was adjusted also additional for family history of CHD. And just take a look on the last model, and in the group of the low risk subject without risk factors or having only 1 risk factors, we saw that those subjects who have high LPLA values have 38 increased risk for incident CHD compared to those with values below 43 milligram per deciliter. Interestingly, in the higher absolute risk group and having 2 and more risk factors, this risk was numerically lower, just 27%, but should be noted here that P4 interaction was not significant. And that is our main message of the study, that LPLA-related risk for future CHD was similar between individuals and very low absolute risk and elevated absolute risk. What we wanted to achieve with this investigation, just to raise awareness in the research community that in individuals who are at low absolute risk, increased Lp(a) is still represent important risk factor for adverse outcomes. And more importantly, to make clear that very low absolute risk individuals with elevated Lp(a) doesn't automatically mean that the subject are the safe side, they are protected from CHD events. So definitely from the clinical point of view, it's also important to see what we can do for our patient. Of course, we need to concentrate on the high-risk population because they are at much higher risk, and we are doing not good, especially taking account the data from Inter-Aspire study showing that only 2% of subjects with the highest risk in the secondary prevention, they have not that control risk factors. But nonetheless, they shouldn't also notice that the individuals with at low risk, they also need our attention. What should we do with this patient? It should be still determined. Probably we need more close monitoring or more strict adjustment to risk factors. We need more data on this. Thank you very much.
Thank you very much, and I see Henry already coming up.
Nobody else is going to come up. No, very interesting, and I think I would just take you back to what you said earlier about attributable risk, right? So if somebody has average or lower risk by whatever calculate you want, and 20-year risk might be 5 to 7% or something like that, but they have a high LPA that hasn't been in that calculator. And then risk may now be 10 or 12%. And that's but there are so many more people at that risk. And just anecdotally, we all, it makes the headlines all the time when some celebrity who's 48 or 55 suddenly falls dead in the street, and they said they were perfectly healthy. Well, there were other risk factors that haven't been measured either, but many of them had a high LPA, almost certainly.
Exactly, that's the point. I think everyone here have at least one patient who was healthy, but suffered heart attack just due to isolated Lp(a) increased concentration. That's the point.
Next question.
Thank you for this data set and your nice presentation. My question is, you showed very low levels of Lp(a), and this reminds me of Florian, your gray scale zone where these Lp(a) is found. So actually, what could you conclude from these data? Is this not the gray zone, but it's a little bit more the high starts there, the high risk for cardiovascular disease? Is this your conclusion, or maybe your conclusion?
I would be more cautious with this conclusion, so to say, because we know that in biomarker population we have slightly lower L values as compared to Copenhagen study, for example, yes. And it's that methodological limitation we have, yeah? But nonetheless, 33 milligram per deciliter is much close to 50 milligram per deciliter as cutoff for high risk, yeah? And I wouldn't say that we need different cutoffs, no, but just I would say it from other way. If we would have even higher value, probably the risk was also higher.
Last question.
Thanks, lovely talk. Your expressed relative risk of something in the order of about 1.4 in both categories seems reassuring at one level, and at another level it seems a little bit at odds with some of the quoted values I've heard during the day of about 6 to 7 times. Could you comment?
No, I don't think so.
Okay, thank you.
Okay. Yeah, I think we have to conclude this session. Thank you very much. Thank you to all speakers and also for the audience here that they raised questions. And I think it's always quite interesting to have a session which is completely dealing with Lp(a). Thank you very much and have a nice evening. And please go to the General Assembly if you are a member of the EAS.
Thank you.